Thank you so much, Dr. Kapoor. How do I advance it? Just Chris? Okay. All right. So those are my disclosures. I'm a hypertension specialist. It's very hard for me to resist making clinical pearls when I hear anything related. So just one thing about minoxidil that Dr. Sisemsky was talking about. There is actually a clinical trial that is ongoing that is led by Northwestern in Chicago, trying to give minoxidil for hair growth in patients who are on chemotherapy and have hair loss. It's actually still ongoing. So we'll see what that trial shows. So I'm going to walk you through quickly about what we need to do to select the proper patient. The first thing for renal denervation, the first thing we need to do is to rule out white coat hypertension. That's really very important. So you need at least 2 weeks of home blood pressure readings to make sure that the number you have in the office, the high blood pressure you see in the office is real. Or you can do a 24-hour ABPM if you have that ability. So that's one. Two, we really need to rule out secondary hypertension before we refer any patient for resistant hypertension, for renal denervation, especially high primary aldo, which is very common and underdiagnosed. So I'll tell you what we usually send at Mount Sinai in our hypertension clinic. When we get a referral for renal denervation, we send the renal panel. I always add a cystatin C to the panel because that gives us a better estimation of the kidney function. The creatinine really does poorly overall when you use it alone. The National Kidney Foundation recommended adding the cystatin C back in 2021 in the measurement of the GFR. We send a spot urine for protein creatinine. We always send an aldo and a plasma renin activity level, preferably a morning level. We usually send metanephrines, although those have a low yield. You don't have to send them, but we typically do send them just to complete the workup with the TSH. And we usually have a Doppler ultrasound in the workup to make sure that the patient doesn't have renovascular hypertension. So the problem with treating hypertension, a lot of our speakers have already, talked about that. It's really compliance and adherence to treatment. And you can see the more medications you're on, the more likely that you're not going to be adherent to those medications. So 6+, you can get up to 80% non-adherence. 4+, 40% non-adherence. So it's really a big problem, and we really need to make sure that the patient is taking the medications before we talk about denervation as well. So how do we define a responder to denervation? It's not standardized, but most of the trials have used a blood pressure reduction of 10 points, which is an office blood pressure reduction, to define a responder. So an office reduction of 10 points or more, a profound responder, 16.5, what I've seen in the studies, would be a profound responder. For the 24-hour mean blood pressure, a reduction of 5 points or more is used to define a responder. We can also use the medication changes to define how much response we have, medication burden, which is a little bit more complicated. And then some trials have used a win ratio analysis to define a responder versus a non-responder. It's a hierarchical approach when they start with like a blood pressure reduction in the office as a step 1, and they go to a step 2, which is the 24-hour, and then they look at the blood pressure, medication burden, things like that to get a win ratio in favor of denervation or the sham. And I'm going to show you here, renal denervation is really a responder versus a non-responder kind of procedure. So you see the green where denervation is, it's thicker, roughly 50% thicker, and it extends, further than the sham. And you see the non-responder, starts later compared to the sham, and it's usually narrower. And that's what's kind of the picture that you get in most of the studies we've had. So the million-dollar question is, who are these responders and how do we find them? And whether you look at the response rates, in the trials, some trials were positive in one aspect versus another. When you look at both, the vast majority had some reduction in blood pressure, whether in the office or the 24-hour blood pressure. So one very important aspect in simplicity 3 is the number of ablations. That's really very important. You really need to make sure that you're doing this properly. And on average, if you do more than 12 ablations on a side, your likelihood of achieving blood pressure reduction is significantly higher. So 21-point reduction in simplicity 3 with 16 ablations or more compared to the sham. And then you see that trend, which is pretty clear. So, and looking at some other markers, one item that is really recurrent in many trials is being on Spiro or an aldo antagonist, mineralocorticoid receptor antagonist. They typically have an amplified response to renal denervation. And again, the total number of ablations. In this series from Belgium, really long term, and you see, denervation is a recurrent theme. You're going to see the same things happen in different trials. So this is over 10 years. And you see the blood pressure reduction, whether the 24-hour systolic versus the office, it's pretty consistent and continuous over the course of time. And in this trial, they found that those who had the second generation radiofrequency catheter, which is the spiral catheter, had significantly more reduction compared to the original one, which is the Flex, which was used in Simplicity 3. I think one of the main reasons, that Simplicity 3 didn't meet the endpoint was the use of the older generation catheter, which only had one electrode, and the fact that they did not denervate the accessory arteries. So in denervation, the key is to do it properly if you want to have a good response. One aspect of response that is also recurrent in these studies is heart rate. So this is a look at the spiral of medicine, which in the trial there was a 7-point almost difference in office blood pressure, a 4-point difference in 24-hour systolic blood pressure. But then when you dissect the results according to the heart rate, you see that those who had a lower heart rate, less than 70, did not have a meaningful response, versus those who had a higher heart rate, who had an amplified response. And this is a 24-hour blood pressure, so 2.2 extra millimeters of reduction compared to the overall trial. And the same thing they found when they looked at the office and at the daytime blood pressures. One interesting analysis I've seen, it's an abstract that was published in one of the meetings. Those who underwent denervation had a significantly lower rate of hypertensive urgencies and the need to visit the hospital compared to those who did not have the procedure. So I'll talk about that at the end. In the guidelines, it's a class 2B recommendation for denervation, whether in patients with resistant hypertension or with uncontrolled hypertension. The same thing is in the European guidelines. It's a class 2B for resistant hypertension and for uncontrolled hypertension. One important aspect I wanted to mention was isolated systolic hypertension. So those patients have a wide pulse pressure. It's actually off-label for these patients. Renal denervation is off-label for a few populations. This is one of them. Another one is patients with chronic kidney disease. We can talk about that at the end. But if you look at the pooled data that we have from Simplicity 3 and from the Simplicity Global Registry, there is actually an 11-point reduction in those who had isolated systolic hypertension compared to those who had combined, CHs combined systolic and diastolic hypertension. So the reduction was meaningful in both arms. Oops. Oh, I missed this one. But that slide showed that, how do I go back? Oh, right. Oh, okay. So here you find the same signals. So the more ablations you have, this is a look at the Global Simplicity Registry. The more ablations you do, the more blood pressure reduction you have. Being on spironolactone and co will also lead to more blood pressure reduction. And the baseline heart rate. So I'll show you that in a little bit. And it's really important when we consider doing denervation is to talk to the patient, because the perception of the patient can be really different from our own perception. And they looked at that in Europe, and they found that patients who were mostly interested in denervation were those patients who considered their hypertension to be a serious and significant problem, or those who had side effects And in surveys, they found that actually up to 40% of patients prefer doing the procedure rather than adding an extra pill to treat hypertension. So listening to the patient, and establishing that partnership is really important. And we should all, I always tell the patients when we talk about the procedure, it's a responder. I try to pick the right patient, and I'll tell you my thought process at the end. I'm going to skip this just for the sake of time. So what's the real benefit of the procedure? You have that continuous blood pressure reduction, which medications do not achieve. I'm going to show you a really nice curve that shows that point. So it improves adherence to treatment. It improves the time in target blood pressure, which is very important. Now we have a lot more data showing that the more time you spend in target blood pressure, the better your outcomes overall. So when you compare denervation versus giving an extra pill, denervation is very well tolerated. It's better for adherence. It's roughly equivalent to adding a medication. I would say on average, 5 to 10 points on average, but I'll talk about the responders in a bit. Cost, obviously, medications are cheaper, but then you want to talk to the patient and see what the patient wants. And it's really this continuous effect. This curve, we've seen in most of the previous talks. You see that nice separation over the 24-hour period that you don't see with the sham procedure. And this is very, very important. When you look at the medication effects, so this shows you people on 1 drug, 2 drugs, and 3 drugs. You see the effect of those medications weaning off, later at night and in the early morning. And you see this gap between denervation and the medicines at this critical time when we know, the highest incidence of cardiovascular events usually occur. And that's really one of the advantages of denervation, that it provides that continuous blood pressure reduction over the 24-hour period, and the effect does not wean off like a medication. So the patients who are the best candidates for denervation, hypertension is a pathway disease. Guidelines are very nice. They give you a frame to treat hypertension by giving you instructions. You start with A and then B and then C, but they don't give you a rationale or a thought process. And hypertension is a little bit more complicated than what the guidelines imply. So it's a phenotype disease, and the patients who respond to denervation mostly are those who are sympathetically driven. And this is a large chunk of our hypertensive population. How can you tell that someone is sympathetically driven? There's no standardized approach. It's a clinical judgment. If you see someone whose blood pressure actually increases when they stand up, that's a clue, and a very important clue, that they're sympathetically driven. That's why I always do a sitting and standing blood pressure in the office, although it's challenging with the time constraints and the MAs don't like it, but it's a must that we have to do. Heart rate we talked about, which is a very clear sign of sympathetic overactivity. One important aspect is nighttime blood pressure. Those who are especially reverse dippers on 24-hour ABPMs. You need to exclude white coat for denervation, but actually those who have hypertension and have a white coat component are actually great candidates for denervation, because those patients are specifically sympathetically driven. When they're in the office, their blood pressure is higher. The patients who are not able to tolerate medicines are obvious candidates for denervation. And then those who go to the ER frequently for hypertensive emergencies and high blood pressure are obvious candidates. Resistant hypertension, as shown in the studies, the guidelines, there is really a noted synergy. So if you have a resistant hypertension patient, you want to get the best result with denervation, try to put that patient on Spiro before you do the denervation. You're going to get a better result, but really, please send the Aldo and the renin before you put the patient on Spiro, because it's a nightmare to do the testing once they're on it. You have to stop it for at least 4 weeks. And one beautiful aspect of denervation, besides the continuous blood pressure reduction, is the fact it's independent of salt intake, which is a very important aspect in hypertension management. Very few drugs work, independently of salt intake. You eat a typical American diet of 4,000 milligrams of sodium a day, your renin level is suppressed. So you can use aliskiren and an ARB and an ACE, good luck, you're not going to get much blood pressure reduction. So calcium channel blockers, work independently of salt intake, but very few drugs do that. Renal denervation is a very important tool that we can use. And this is the orthostatic hypertension I talked about, often overlooked, but very important. And you see the signal with it was actually stronger than all the other signals. This is from the pooled radiance analysis. So really, looking at the big picture, we want to prevent cardiovascular disease, cardiovascular events. And the priority I usually give to those patients who have target organ damage. If someone had a stroke, I don't think twice about doing a procedure I know will help in reducing blood pressure and preventing another stroke and disability. Someone with severe LVH, proteinuria, it's a big picture kind of thing, and it's a phenotype. One last thing, younger patients, they respond better to the procedure, as shown in multiple studies, because they have better vascular compliance. So, don't wait until you get your patient at 77 or 78 years, they lose their vascular compliance to do the denervation. This is a procedure really tailored for people in their 50s and their 60s. Oops. And who are the patients who should not get the denervation? Those who have renal artery stenosis should not get the denervation. Oops. Those who have a renal artery aneurysm, who do not have the adequate sizes for treatment. FMD, we should not do denervation in general. Those who have stents, it's not an absolute contraindication, actually. If you have a single functioning kidney, that's an absolute contraindication in general, and obviously in pregnancy. A follow-up, there's no standardized approach. We usually, follow up with the patient shortly after the procedure. Usually, I don't change the medicines unless I see some dramatic blood pressure reduction. I usually, send the patient on their home blood pressure, same medications. And then, we bring them in for a follow-up in like 2 or 3 weeks, and then we see what kind of blood pressure we have. And then, follow up 3 to 6 months afterwards. And that's it. Thank you so much.